Hello everyone, my name is Caitlin Bernard and I'm a PGY1 pharmacy practice resident in the program with the University of New England Martins Point Healthcare and Hannaford Pharmacy. And I was asked to give this presentation into the training guide for the administration and dispensing of Naloxone, given the recent passage of dispensing of Naloxone to the public in Maine. First, I don't have any conflicts of interest. The objectives for today's presentation includes describing risk factors of opioid abuse and overdose, as well as how to recognize and respond to an overdose situation, discuss pharmacist responsibilities and requirements under the new Maine regulations surrounding dispensing Naloxone to the public, including how to identify individuals who are at risk for an overdose. Next, we'll talk about formulation-specific information, including indications and contraindications to the use of Naloxone. And lastly, describe proper storage and administration techniques for the dispensed Naloxone formulation. So here we have the 13 training requirements that are listed in the Naloxone Law in the Maine Board of Pharmacy. And the objectives that I just spoke of are encompassing of all 13 requirements. And so let's just get into the meat of the presentation. To start off, I wanted to provide some background information in terms of the nationwide and then specifically Maine opioid epidemic. We are currently in the middle of a major public health crisis with the nationwide opioid epidemic. In 2015, there were just over 52,000 drug overdose deaths in the nation. This is a threefold increase since 1999 in the United States. This number averages out to be just over 100 people dying every single day from a drug overdose in the United States. Of the deaths reported in 2015, 63% of those had involved an opioid medication. Many of these could have been prevented. To further complicate matters, not only are prescription opioids a concern, but also drugs that are laced with fentanyl or any of its derivatives. It has been in the news recently that fentanyl is being added to or is a substitute for heroin because it offers several advantages. Because of its potency, it requires less bulk and weight for distribution and transportation and can be reliably manufactured. Those who use opioids may prefer fentanyl because it is highly lipid soluble, making it very rapid acting and about 40 times more potent than heroin. The duration of action of fentanyl is only 30 to 60 minutes compared to 4 to 5 hours for heroin. In addition to fentanyl, there are about 15 other analogs that have been identified by the DEA, such as acetylfentanyl, butyrylfentanyl, and carfentanil. Carfentanil is an extremely potent opioid that is only used for veterinary use with large animals, since it is 100 times more potent than fentanyl. Heroin fluctuation in purity due to the potential contamination with fentanyl is a known major overdose risk because people may not know what they are injecting. The reason I mention all of this is because there is a drastic change in the time to respond to an overdose for prescription opioid or heroin versus fentanyl. Because of its potency and fast onset, fatal respiratory depression can occur within 2 minutes with fentanyl compared to 30 minutes with heroin. Also in 2015, the Department of Health and Human Services recognized that opioid-related overdose are a major public health concern. They produced a report that identified 3 priority areas to address. The first being increased safe opioid prescribing, second, increasing naloxone access, and medication-assisted treatment. Although Maine has addressed the first bullet point with the new opioid limits, now we are working on the second, to increase access to naloxone. It should be of no surprise that one major contributor to this opioid epidemic has been prescribing. The amount of opioids prescribed per person was 3 times higher in 2015 at 640 morphine milliequivalents than in 1999 at 180. Furthermore, this is a map of the United States depicting the amount of opioids prescribed per person in 2015 by county. The amount of opioids prescribed per person is represented on a blue color spectrum, with the darkest almost black representing the greatest amount at an astonishing 959 to just over 5,500 morphine milliequivalents per person, and the lowest being a light periwinkle blue color at less than 453 morphine milliequivalents. The white areas here are insufficient evidence to calculate a morphine milliequivalents per person. It appears to be very variable. However, there are clusters around Tennessee and out west with high opioid prescribing with the darkest of colors. Also from this map, you can see that the majority of Maine has darker blues and black. Alright, so I do have some good news in terms of opioid prescribing. This first image on the left-hand side shows the percent change in prescription volume from 2010 to 2015 in northern New England. The green is good and represents a decrease in volume, and the red-orangish color is bad, and it is an increase in opioid prescription volume. Overall, the majority of Maine is in the green with a reduction in prescription volume. Although this is a reduction in volume, that doesn't necessarily mean a reduction in morphine milliequivalents. As we should very well know, in the state of Maine, it has taken steps to decrease the prescribing of opioids with the implementation of the less than 100 morphine milliequivalents and the acute versus chronic designations. Prior to this implementation, there was already a decrease in prescribing by 21.5% in the state of Maine from 2013 to 2016, with an even further decrease since that implementation. From 2013 to 16, Maine had the fourth steepest decrease in the country, and the nationwide opioid prescribing rates also decreased by 14.6%. This slide shows a graphical representation of the number of opioid overdose deaths by drug type over time in the state of Maine. Since around 2002, the number of prescription opioid deaths has remained relatively stable. The total deaths in the state of Maine has largely been driven by the illicit opioid deaths, with the similarly shaped lines. Since 2013, there has been a sharp increase in the amount of illicit opioid overdose deaths. Specifically in Maine, in 2015, there were 272 opioid overdose deaths, which increased to 376 in 2016. This was a 31% increase from 2014. Of the deaths in 2016, 111, or 41%, were due to pharmaceutical opioids, and more than 8 in 10 involved opioids including heroin, fentanyl, or prescription drugs such as oxycodone. Due to the urgency of the opioid crisis, the Opioid Task Force of Maine was created in early 2017. It was designed to examine the current laws in the state addressing opioid and heroin use, including existing laws concerning law enforcement, prevention, treatment, and recovery. The Maine Opioid Task Force published a report in December of 2017 with the following findings. There was a total of 376 drug-induced deaths in Maine in 2016, which averages out to be a little more than 1 death per day in the state. This was also a 38% increase from that in 2015. Of the 376 deaths in 2016, 88% were accidental overdoses and 10% were suicides. Only a quarter of the drug overdose deaths were treated with Naloxone. 84% of the deaths in Maine were caused by at least one opioid, either prescription or illicit, whereas 79% were caused by 2 or more drugs, and 63% of the deaths were caused by either fentanyl and/or heroin and morphine. Lastly, a really interesting statistic being that 16% of the overdose deaths in 2016 were attributable to cocaine, which was a 71% increase since 2015. In February of 2018, the Attorney General Janet Mills released the drug death statistics for 2017 in the state of Maine. In total, there were 418 drug overdose deaths in 2017, with again another increase, specifically an 11% increase from the previous year. Although this increase was not as significant as the previous year increases, so this is some sort of progress. The report mentioned that this increase in death has been largely driven by the increase in deaths due to illegal fentanyl and its analogs, since heroin overdose deaths has decreased. As mentioned on the previous slide, there has also been an increase in the number of cocaine overdoses, as well as methamphetamine. Furthermore, most of the deaths were caused by 2 or more drugs, with the average amount being 3 medications. Similar to the previous year, the majority of deaths, or 85%, were attributable to at least one prescription or illicit opioid. An increase from the previous year, however, naloxone was detected in only 31% of the overdose deaths, which was up from 25%. This shows that someone had tried to revive the patient, but the attempt was too late. Of those who overdosed from prescription opioids, in most cases, the individual had not been prescribed that medication. This is something very important to keep in mind when counseling patients, not only to take their medications as it has been prescribed to them, but to also keep it in a safe place away from children or other adults. This is a map of Maine showing the number of deaths per 100,000 residents in 2016. The counties with color had more than 10 deaths, since data is only available for those counties with greater than 10 deaths. 20 years ago, drug overdose deaths in Maine were rare. In 2015, 5 out of the 16 counties in Maine had 10 deaths or more. And last year, the number has increased, has actually doubled in fact, to 10 counties having at least 10 deaths, as pictured above. Similar to this picture, the Attorney General's report mentioned on the previous slide stated that the highest number of overdose deaths, which is 26%, occurred in Cumberland County, with 57 deaths occurring in Portland. This is more than 1 per week. York County was the second highest with 82 deaths, or 20%, and 23 deaths were in Biddeford. Lastly, Penobscot County had the third highest number with 65 deaths, or 16%. The top 3 counties are encompassing of some of the largest cities in Maine and along the 95 corridor. The average age of drug overdose deaths has remained relatively stable at around 41 years old. This is also close to the average age of the state's population. Alright, so now we're going to knock off one of the 13 training requirements, and we will talk about how to identify an at-risk individual for an opioid overdose. So when we really think about it, any patient who takes an opioid is at risk of an overdose. It can occur in anyone, no matter if they take opioids chronically or are newly started on an opioid medication. However, the risk does increase in those who take long-acting opioids. In an ideal world, every patient who receives an opioid prescription would also be prescribed naloxone. There are several risk assessment tools, such as the Opioid Risk Tool, ORT assessment, which can be found online, and it is used to assess one's risk, whether low, moderate, or high. To determine this, it uses the risk factors that I'm about to talk about to determine where one lies on the spectrum. Pharmacists, especially in Maine with the new opioid limitations, are mentally flagging patients who are over the 100 morphine milliequivalents. This designation puts them in a high-dose opioid category. Again, anyone who takes an opioid is at risk of an overdose. Therefore, pharmacists should also be flagging those who take over 50 morphine milliequivalents as someone to be counseled on the risks of taking the opioid medication, as well as counseled on also having some naloxone on hand just in case. But when we talk about the red flags to opioid or substance abuse, there are several that come to mind. We have all heard of the typical red flags, like using multiple pharmacies and doctors, which has decreased since the mandatory PMP implementation for both pharmacies and prescribers. However, there are several other major risk factors. Those who are at the highest risk are those who are dependent both physiologically and psychologically on opioids. Another major risk factor is someone who has a prior history of an overdose. Other high-risk groups include those who may have developed tolerance to opioids and stopped taking the medications for whatever reason, which they then lost their tolerance and then have restarted using or taking opioids. This can be related to someone being incarcerated or in an opioid detox program. Depending on how much time they spent in there, they could have potentially lost some, if not all, of their tolerance to opioids. they would most likely not be able to tolerate the same dose as they would have prior to incarceration or detox, and could result in an overdose. As a side note, another risk factor that I had previously mentioned in the previous section is the purity of the person's drug of choice. It could be straight heroin or cocaine that they buy, or it could be laced with fentanyl. This matters because of the amount or dose that the patient would ingest or inject. They would not be able to tolerate the same dose if it was laced with fentanyl or if it was pure, which could potentially result in an overdose situation. Other additional risk factors include difficulty accessing emergency medical services, whether that be distance-wise or financially. Again, an overdose from opioids can occur within 30 minutes. For those who live in rural Maine, it could be too late by the time that the patient is first found, and even longer until EMS arrives. So having some naloxone on hand could save the patient's life or simply prolong life long enough until more medical help arrives. Patients with renal or hepatic impairment could result in the increased exposure and duration of the opioid in their system. For example, if someone has chronic kidney disease in which the person has impaired clearance, the opioid would be sticking around longer in the patient's body. Or, if someone also concurrently has hepatitis C, this could result in the impairment of metabolism of the opioid in the liver, resulting in a decreased overdose threshold. Additional risk factors include history of mental illness or other psychological disease such as OCD or ADD, or concomitantly taking opioids with any respiratory diagnosis like COPD or sleep apnea. Opioids can cause respiratory depression, in which the respiratory illness or diagnosis could exacerbate this. And lastly, taking any CNS depressant, whether over-the-counter or prescription, in addition to sedative, benzodiazepine, or antidepressant use in combination with an opioid, can have synergistic effects for the same reason as with someone who has respiratory disease. This combination could result in a decreased respiratory drive. Now we will go into the Maine Board of Pharmacy's new regulation for the authorization to prescribe and dispense naloxone. Under this new rule, pharmacists may not dispense naloxone without a prescription, standing order, or collaborative drug therapy management agreement unless authorized to prescribe. With immunizations, some pharmacies use standing orders, and the same with naloxone. However, with this new regulation, that will not be necessary to have a standing order or collaborative practice agreement with a physician. Under Maine's authorization to prescribe and dispense, prior to this, pharmacists must obtain 2 ACPE-approved CE hours of training related to the 4 items listed on this slide. This includes writing of naloxone prescriptions, as well as the safe dispensing, counseling, and naloxone's place as an antidote in opioid overdoses. In addition, the 13 training requirements listed on an upcoming slide should be included. If you are listening to this presentation and complete the assessment question and evaluation survey at the end, you are fulfilling the requirement. There is no formal application to be authorized to prescribe naloxone. However, the pharmacist shall retain the record of this training and present it to the board upon request or if subject to a CE audit. The documentation of completion of this particular CE will be available on NABP's CE monitor. The authorized pharmacist may prescribe an oral, injectable, intranasal, or any other form of opioid antagonist and the necessary medical supplies to administer that naloxone to a patient that the pharmacist reasonably determines to meet the eligible patient criteria. Eligible patients will be discussed on the next couple slides. The pharmacist may only write and dispense this prescription to meet the need on hand, not for the purposes of the patient taking it to another pharmacy. Authorized pharmacists may also prescribe naloxone emergency rescue kits. These kits must be labeled to include the expiration date. In addition, there should also be patient education information included. These kits can be dispensed to a patient, caregiver, or first responder. A record of prescribing and dispensing rescue kits must be kept. These 13 additional requirements include the risk factors for abuse and overdose, and how to recognize and respond to an overdose if it should occur, but also on how to prevent an overdose from occurring. In addition, education on naloxone's indication for use, contraindications, proper storage, expiration, and administration techniques should also be provided. Lastly, as with immunizations, there are certain required patient education and documentation components that must be done, which I will talk about shortly. Those who are eligible to receive naloxone under the Maine protocol is extremely similar to those who would be considered at risk for an overdose, as I previously have mentioned, which it should be that way. So anyone who meets any of those risk factor criteria would be eligible. For example, in someone who has a prior history of an overdose or substance abuse, or if they have a recent release from prison or detox program. The only difference is that naloxone can be requested from the patient themselves or those who are members of an at-risk patient's immediate family or friend, or to someone who is in a position to assist the person if they experience an opioid-related drug overdose. At one point, the board was going to include a clause stating that naloxone could only be dispensed to those over 21 years. However, the age restriction has been lifted, and it can be dispensed to anyone of any age. Again, this continuation of the eligible recipients looks very familiar to the risk factors previously discussed, like receiving high-dose opioids or difficulty accessing emergency medical services. Some additional important things to note that were not previously mentioned is that smoking, cardiac disease, or those who inject opioids in combination with taking an opioid prescription would be considered high risk and eligible to receive naloxone under this protocol. Now we will get into the required counseling and documentation components to the new rules. The pharmacist who dispenses the naloxone product to the patient or caregiver under this rule shall provide the required counseling components listed on the next slide. The offer to counsel is required, as with all new prescriptions. However, if the patient or caregiver refuses counseling, a refusal should be documented. The counseling should include both written and verbal instructions on the proper response to the emergency, including instructions for seeking medical attention. Pharmacy interns can counsel on naloxone products under the direct supervision of the dispensing pharmacist. However, the dispensing pharmacist must ensure that all pharmacy interns are appropriately trained on the opiate antagonists and can meet all of the counseling requirements. So again, in the minimum counseling components, it should include written instructions on how to properly respond to an overdose, which is to call emergency services as soon as practical, either before or after administration of naloxone. The other counseling requirements include both verbal and written instructions on how to identify an opioid overdose and the steps in responding to the situation, along with how to administer the dispensed naloxone product, the proper storage and expiration of that product, as well as the risk factors for and ways to prevent an overdose. We have already discussed some of these components, and the others we will go into in a little bit. Lastly, there should be some information provided to the patient on where someone could get a referral for substance abuse treatment. Pharmacists must document in their respective pharmacy systems each person who receives a naloxone prescription under this protocol. The required documentation must include the dispense date, the name of the patient at risk if it is known, or the name of the patient requesting or receiving the naloxone. In addition, the product name, dose and administration route, and the name of the prescribing and dispensing pharmacists. The dispensing pharmacist is the one who reviewed and provided the patient or caregiver with the educational materials that is appropriate to the dispensed naloxone formulation. Again, this documentation also applies to the naloxone emergency kits. Just like with immunizations, the pharmacist must notify the individual's physician that they have received this particular vaccine. The pharmacist must provide the patient's physician or healthcare provider with written notification, either via fax or other method, that naloxone was provided to their patient under this protocol. This notification should include the patient or individual's name, the opioid antagonist prescribed or dispensed by the pharmacist, as well as the dispense date. If the physician or provider is not known, it must be documented as such in the pharmacy's computer systems. I wanted to include a short section on what your liability is as a pharmacist in both the prescribing and the dispensing role, because I know that this can be a bit nerve-wracking, especially since it is new. As part of the 2017 Maine Naloxone Overdose Prevention laws, both prescribers and dispensers have some sort of immunity. Prescribers have immunity from criminal prosecution, civil liability, and professional sanction for prescribing, dispensing, or distributing naloxone to a layperson. Also, dispensers have immunity from civil liability and professional sanctions. However, all are required to act with reasonable care. Remember that naloxone will not possess harm to a patient if given naloxone and they do not have opioids in their system. It will simply just not work. Keep this in mind when dispensing to patients who may be nervous about administering to a bystander, or if you are concerned that you may have to give naloxone at your job. Then lastly, something that you may want to counsel your patients about, especially since I have read that many times when someone overdoses and they are given naloxone, no one calls 911 because they are afraid of having the police called. Under the Good Samaritan Law, you cannot be prosecuted for having a small amount of medication or drugs when you seek help in an overdose situation. The overdose victim is also protected under this law. However, it does not protect you or the victim against other crimes or warrants. Now we will move into talking about the reversal agent itself. Naloxone is a specific antidote to opioids. It is an opioid antagonist that is highly specific and has a high affinity to the opioid receptor. It actually possesses a stronger affinity to the opioid receptors than the opioids themselves. It effectively knocks them off of the receptors for a short amount of time, reversing the overdose. There are 3 important things that you should know about naloxone. The first being that it will only have an effect if there are opioids involved. These drugs include morphine, codeine, oxycodone, hydrocodone, and the illicits such as heroin. It will not have any effect on overdoses caused by benzodiazepines, barbiturates, cocaine, amphetamines, or other stimulants. Lastly, if administered to a patient who does not have any opioids in their system, it will not cause them any harm. They will have no side effects. Nothing will happen to them. So again, it does not harm the patient if someone is administered naloxone and they do not have any opioids in their system. Naloxone is indicated for the emergency treatment of either a known or suspected opioid overdose. Contraindications to the use of naloxone include hypersensitivity to naloxone itself or any component of the formulation, including any inactive ingredients. Side effects of naloxone are primarily through the acute opioid withdrawal induction. Symptoms of this include body aches, fever, sweating, irritability, nausea, vomiting, diarrhea, as well as increased blood pressure and increased heart rate. The important thing to know is that these symptoms are generally not life-threatening to the patient. They just make them feel very uncomfortable and very unpleasant. These symptoms that are induced by naloxone generally disappear over the course of action of naloxone. Naloxone's duration of action is anywhere from 30 minutes to 90 minutes. Naloxone also poses no potential for abuse, and patients do not and cannot develop tolerance to the effects of naloxone, so it can be used no matter how many times a patient has used it in the past. There are several warnings and precautions to the use of naloxone, the first being the risk of recurrent respiratory and CNS depression. Naloxone can reverse the effects of opioids within 2 to 3 minutes. However, it is important to note that the duration of most opioids does exceed the duration of action of naloxone itself, especially when we're talking about long-acting opioids. That is why it's very important to keep the patient under continued surveillance because repeat doses may need to be given. Second, the risk of limited efficacy with either partial agonists or mixed agonists and antagonists. This means that the reversal of respiratory depression when administered naloxone could either be incomplete or it could require higher naloxone doses. The precipitation of severe opioid withdrawal can occur with naloxone administration. It can either precipitate an acute withdrawal or it can even unmask pain in those who regularly take opioids. Lastly, there are some pregnancy-related concerns. Naloxone use generally is not recommended for use in pregnant women because it can cross the placenta and precipitate withdrawal in the fetus as well as in the mother. However, in situations of life-threatening overdose, it is recommended to administer naloxone to pregnant women. There are 4 naloxone formulations that we will be discussing throughout this presentation. These 4 are the formulations that will be able to be dispensed by pharmacists in the state of Maine. There are 2 intranasal formulations and 2 intramuscular injectables. The first one being a generic naloxone syringe in which an intranasal adapter must be purchased and attached separately. We then have 2 branded products as the Narcan nasal spray and the FZO autoinjector via intramuscular injection. Lastly, there are the generic vials made by Hospira and Mylan that either come as single dose, which is 1 ml, or multi-dose, which is 10 ml vials. On the next 2 slides, we have a naloxone formulation comparison chart that I thought was super helpful in deciphering between the different formulations. I found this chart on the prescribetoprevent.org website. Going from left to right, we have the intranasal generic syringe, next the branded Narcan nasal spray, the 2 generic injectable vials, and lastly the autoinjector, the FZO. The only 2 products that do not require any assembly include the Narcan and the FZO autoinjector. On the other side, for the intranasal generic syringe and the injectable generic vials, their doses are titratable. Most importantly, I feel, especially for our patients, is the row of cost per kit. It is very important to know relative costs because patients may be purchasing these out of pocket, or on the other side, knowing the formularies in terms of the patient's insurance. It should come as no shock that the FZO and the Narcan nasal spray are the 2 most expensive formulations. Next rows, the NDC manufacturer and customer service, I thought were very helpful just to kind of have as a quick reference guide for you. These may change, so just keep an eye on that as well. On the second slide of the formulation comparison chart, we have what the prescription and the quantity would be in the naloxone kit or what would come in with the box or the package for the respective formulations. Then we have the directions of what it would be for each formulation. I'm not going to go into this now because we'll go into this in the individual formulations in just a minute. The one thing that I will talk about here are the storage requirements. All of the formulations require that they be protected from light. Also, they require them to be stored at room temperature. However, the temperature ranges vary from formulation to formulation, and so the respective ranges for each product are listed here. On the previous slide, there was a sort of pictorial representation of the relative cost of each formulation of naloxone, but this slide provides more specific numbers. First, we have the average wholesale price, or AWP, of the generic naloxone vial or syringe coming right around $30 a piece. However, with the intranasal route, we have the added expense of the adapter, which comes to about $50. The Narcan nasal spray comes in right around $150. However, for first responders, community naloxone programs, or other qualified public interest groups, it could potentially be somewhere right around $37 per device. The manufacturer of Narcan also offers 2 free cartons, which equals 4 doses to high schools, and 4 cartons or 8 doses free to eligible colleges. The Evzio autoinjector is right around $4,900. Some patients may qualify for patient assistance programs, and the patient can go onto the manufacturer's website for more information on that. Some insurances do carry one or several naloxone formulations on their formularies. For coverage determination, I use the fingertip formulary website, and of course, both coverage and AWPs are subject to change. For insurance plans, I picked out the most common in Maine that you typically see, as well as some national plans. The naloxone generics are covered and preferred by Anthem, CVS Caremark, Cigna, and Aetna. For Maine Care, the generic naloxone is covered, but it is not preferred and it requires a PA. This formulation is not covered under the following plans, both Harvard Pilgrim and TRICARE. For the most part, this coverage stays the same for Narcan, except that it is actually preferred for Maine Care and TRICARE. Lastly, for Evzio, the only health plan that it is preferred is with the Department of Veterans Affairs. Through Maine Care, it is covered, however, it is non-preferred and does require a PA. Evzio is not covered under Harvard Pilgrim and Blue Cross Blue Shield. The rest of the health plans, Evzio is covered, but it is not the preferred agent. This means that it is either on a higher tier, such as a tier 3, or requires step therapy or a PA to be covered. This table was just to provide you with a general idea of the cost and coverage for the naloxone formulations. A couple slides detail some billing pearls that you may need to be aware of when implementing the naloxone protocol in your pharmacy. Prescribing the naloxone to the patient under this protocol is different than having a standing order physician. Because you would be billing under their MPI or information, compared to using your own individual MPI as you would be prescribing using this protocol. So you may need to apply and or register for an MPI, your own individual MPI, in order to submit a claim to the insurance through your pharmacy's billing systems. Even then, some insurances may not recognize this MPI as billable, so they may still not cover it. Some of the items, such as the other necessary medical supplies to be dispensed along with the naloxone, including the nasal atomizers and the syringes, may need to be billed as durable medical equipment or DME, depending on the insurance. In addition, some insurances may limit the coverage of the prescription being dispensed to the patient with the intent to potentially use on them rather than just dispensing it to any individual caregiver or friend. As a prescriber and prescribers only, not dispensers, you may also be eligible to bill for the counseling associated with the dispensing of naloxone. There are certain codes for various insurances to be used for certain scenarios, such as when using the screening, brief intervention, and referral to treatment tool to bill for counseling associated with how to recognize an overdose and how to administer naloxone. Use the following procedure codes to bill for services through commercial insurance, Medicare, or Medicaid. These procedure codes are based upon the amount of time you spent counseling the patient. If not using the CBIRT to bill for services, another way could be documenting the time spent with the patient along with the evaluation and management or the E&M codes. If using another evidence-based opioid screening tool for which you would be using and analyzing the tool's results, you could submit under the CPT code 99420 for those with commercial insurance. I just wanted to provide you with some additional considerations to make everyone aware of, since billing for counseling services is kind of outside the realm of the typical filling, submitting a pharmacy claim to the insurance, and dispensing roles as pharmacists in the community setting. Potentially, somehow, it could be worked into the back end of the pharmacy's billing systems to automatically submit for these services when a naloxone claim goes through. These may or may not pertain to you, however, I just thought that they were interesting to note. The first formulation we'll talk about is the generic naloxone nasal spray. This formulation comes separately as a capsule which contains the drug and a syringe. In addition to those two parts, you will also need a nasal atomizer, which is the white cone in this demonstration on the right. So the first step in the administration process is to take off all of the yellow caps which are on the syringe. Next, you want to screw on the white cone, which is the nasal atomizer, until it fits snugly. Next, you want to take the purple cap off of the capsule of naloxone and gently screw that capsule into the syringe barrel. When you're ready to administer the naloxone, insert the white cone into the nostril. Give a short, strong push so that the liquid inside the capsule will atomize and aerosolize into the patient's nose. You want to administer approximately half, or as close as you can get to half the dose, into one nostril. Remove the white cone, place it in the second nostril, and administer the remaining portion. Because it's such a large volume that needs to be administered, that's the reason why you should administer approximately half into one nostril and the remaining into the other nostril. The storage requirements for this formulation include storing the box or the kit at room temperature and protecting it as best as you can from light. There should be an expiration date on the box containing the capsule and the syringe. However, just a general rule, you should replace the kit and the syringe and the capsule before the expiration date on the box. The last thing to know when administering naloxone to anybody is that if there's no reaction in approximately 2 to 3 minutes, you wanted to administer a second dose of naloxone. As I just mentioned, if additional doses of naloxone are needed, they can be given approximately every 2 to 3 minutes until emergency services arrive. If repeat doses are needed, you must use a new nasal syringe with each administration. You cannot reuse these syringes. What needs to be dispensed, the necessary supplies that should be dispensed to the patient for this generic naloxone nasal spray kit, are 2 2 ml naloxone syringe systems and 2 mucosal atomizer devices. Both the onset and the side effects associated with this particular formulation will be a little bit variable depending on whether we're talking about the intramuscular or the intranasal formulations. For the intranasal formulations, the onset is approximately 8 to 13 minutes. And the side effects, some of them are the same, including pain and increased blood pressure, but with the intranasals, additional side effects include headache or nasal dryness, congestion, or edema. The second formulation we'll talk about is the branded Narcan nasal spray. This comes as a pre-filled single-dose intranasal spray. The first step in the administration technique is to peel back the package and remove the device. Second, place the tip of the nozzle in either nostril until the fingers touch the bottom of the patient's nose. Lastly, press the plunger firmly and release the dose into the patient's nose. Again, differing from the last generic naloxone syringe, you want to administer the full spray into one nostril. The storage requirements for the Narcan nasal spray include keeping it at room temperature, and it should not be frozen. It also must be protected from light. Similarly, the box should be replaced before the expiration date. Similar to the generic nasal spray, additional doses can be given every 2 to 3 minutes until emergency services arrive. If repeat doses are needed, use a new nasal spray device with each administration. But with this particular one, if you give the first dose in the left nostril, the repeat dose should be given in the other or the right nostril. The necessary dispensed supplies to the patient should be one box, and one box does contain 2 blister packages with a single nasal spray, which would be 2 doses. Again, the onset of the nasal spray includes the approximation of 8 to 13 minutes for an onset and the same side effects. Next, we have the injectable naloxone vials. With this particular formulation, it's important to keep the environment as sterile as is possible and practical. When we talk about aseptic technique and removing caps from vials, we usually want to swab with alcohol the top of that vial. However, in this sort of emergency circumstance, you may not have access to that. And so when you remove the cap from the vial, just make sure to not touch the top of that vial. The first step in the process is to check to see if the solution inside the vial of naloxone is clear. If it is not, you do not inject it. The first step in the process of administration is to remove that cap, as I had previously mentioned, and uncover the needle. Insert the needle through the rubber stopper of the vial and turn it upside down. Pull back on the plunger of the syringe and withdraw 1 ml. If you have the 1 ml or the single dose vial, withdraw the full contents, which is approximately 1 ml. If you have the multi-dose vial, withdraw back to the 1 ml mark. When you're ready to inject or administer the naloxone to the patient, inject the full dose or 1 ml of naloxone into either upper arm or the thigh muscle as depicted on the right-hand side of the slide. Store the medication at room temperature and protect it from light. And you want to replace the vials before the expiration date on the vial. Similarly, if additional doses of naloxone are needed, they should be administered at a frequency of every 2 to 3 minutes until help arrives. For repeat doses, new syringes should be used with every dose. This is to try and maintain a sterile environment as much as possible. An additional counseling point for this particular formulation should be the proper disposal of the syringe and needles. If the patient does not want to have the additional expense of a formal sharps container, you should counsel them on having an at-home one, including an empty laundry detergent bottle or an empty coffee can, some sort of container that is impenetrable. The necessary supplies to be dispensed to the patient for this naloxone kit includes 2 vials and 2 3 ml syringes with the needles attached as 23 to 25 gauge and 1 and 1.5 inches long. Alcohol wipes are optional, again trying to keep that environment as sterile as is possible. Different than the intranasal, the onset of action is a little bit quicker with the intramuscular formulations. The onset of these are approximately 2 to 5 minutes. They do have different adverse reactions than the intranasal, however a little bit similar, including the abrupt withdrawal of the opioid, as I had previously mentioned, and the injection site reactions. The fourth formulation we're going to talk about is the Evzio auto-injector. It comes as a pre-filled, voice-prompted auto-injector that can either be administered subcutaneously or intramuscularly. Prior to using it, we want to check the solution for any discoloration or precipitation. In general, we're going to inject into the anterolateral aspect of the thigh and through clothing if it is necessary. If administering this to a child less than 1 year old, you want to pinch the thigh muscle while injecting. We're going to go over step-by-step process in just a minute. The storage requirements of Evzio is to keep it in the outer case that is provided and keep it at room temperature. If the solution is discolored or a precipitate is present, or it is close to the expiration date on the box, you want to replace. Again, any repeat doses of naloxone can be administered every 2 to 3 minutes until EMS arrives. The necessary supplies to be dispensed to the patient is just 1 box. 1 box does contain 2 active Evzio auto-injectors with 1 Evzio trainer. If patients or their loved ones are hesitant and timid and anxious about using Evzio on their loved ones or on anyone in general, frequent use of the Evzio trainer is definitely recommended. The onset and the adverse effects are similar to what would be experienced in the previous naloxone intramuscular injection. Although the Evzio is a voice-prompted auto-injector, I wanted to give a visual representation of what is a step-by-step process for the administration of Evzio. The first step is to pull the Evzio out of the outer case, and don't proceed to step 2 until you're ready. Step 2 is to pull off the red safety guard and do not touch the black base. That is where the needle comes out of. Last step in the process is to place the black end of Evzio against the outer thigh and through clothing if that is necessary. Placing the black end against the outer thigh and pressing firmly, and hold that in place for 5 seconds. After the 5 seconds is up, you can then remove Evzio. This slide provides several quick reference videos on the demonstration of how to properly administer the specific naloxone product. These videos were done by a pharmacist and are very helpful to better understand the proper administration technique rather than just listening to me talk you through it. The first video is approximately 8 minutes long, but it goes through all 4 naloxone formulations. I would recommend watching this video now or at the end of this presentation and periodically as a refresher. The next 4 videos are the same demonstration videos as are in the full 8-minute video. However, these would be a good reference guide which you can either watch now and or later as a quick refresher on that specific product before dispensing naloxone to a patient if needed. I also added the video links to the slides on each individual naloxone formulation as well to help with the quick navigation to the page. Now that we've talked about the 4 naloxone formulations, we're now going to dive into the required patient education component. As part of the required patient education component, I'll be mainly talking about 4 steps. The first being recognizing the signs and symptoms of an overdose. Second, administering naloxone and emergency response instructions, and then we'll talk about what to do afterwards. First, we'll talk about the common signs and symptoms of an overdose. Here are the 5 common signs and symptoms that a person is overdosing from opioids, and the number one being that the patient won't wake up, is unresponsive. And this is very similar to the initial kind of reaction when we're approaching doing a CPR or someone is found down, in terms of shaking their shoulders and yelling their name, as well as giving them a sternum rub with your knuckles. And if the patient is truly unresponsive, look for their breathing. Is their breathing slowed or is it just stopped completely? This kind of relates to hypoxia in terms of blue and gray lips and fingernails. Kind of a third thing to check would be their pupils. Are they pinpoint? Are they normal? In terms of an opioid overdose, they will be pinpoint pupils. And lastly, they'll have pale and clammy skin. Now that we identified that the patient is indeed overdosing from an opioid, we're going to talk about next the take-home points of administering naloxone. We spoke about this before when we were talking about the formulations individually, but again, just to review, with the intranasal generic naloxone syringe, we want to remove the colored portions, screw on the a nasal atomizer, and insert that naloxone canister just snugly. In terms of administration, we're going to do approximately half a syringe into one nostril and the remaining dose into the second nostril. Conversely, we have the Narcan nasal spray, in which you administer the full dose into one nostril, and if a second dose is needed, you use the other nostril. For the intramuscular generic naloxone, you're going to drop 1 ml, and the 1 ml out of the 1 ml or the single dose vial will be the entire contents. If it is the multi-dose vial, you just drop 1 ml into the syringe and inject into either the deltoid or the thigh muscle. With the Evzio auto-injector, it will speak at you. However, remove the red piece and inject into the outer thigh with the black end down. Now that we've reviewed administering naloxone, we'll talk about emergency response instructions next. Now that we have reviewed how to administer naloxone with the key points on the previous slides, what do you do then? Call 911. Make sure to say that the patient is unresponsive and is not or is struggling to breathe, along with providing a clear address and location. Begin CPR or rescue breathing as soon as possible, and either or can be used, and that should be based upon the rescuer's training level. What rescue breathing is will be discussed on the next slide. If you are alone when you find the patient, give CPR or rescue breathing for about 2 minutes before leaving to get naloxone if it's not physically around you, or flagging down EMS services. Rescue breathing should be started if the patient is not breathing on their own. If naloxone isn't readily available, or for a few minutes while waiting for the naloxone to take an effect, rescue breathing is used to augment the breathing until the naloxone starts to work. First, we want to make sure that nothing is in their mouth that would be blocking their airway. Place one hand on their chin and tilt the head back, as demonstrated in the picture on the right. With the other hand, pinch their nose closed and administer 2 slow breaths and look for their chest rising. Continue at the rate of 1 breath every 5 seconds until the patient starts breathing on their own or help arrives. So we were able to identify that the patient was overdosing, and we were able to administer the naloxone, call 911, and perform some sort of rescue breaths or CPR. So now what do we do? All right, so now what? We've called EMS and they're on their way. We've administered at least 1 dose of naloxone, and every 2 to 3 minutes thereafter, if the patient needs a second or third dose, if you have it on hand. Outside of that, it's very highly recommended that someone stay with the patient and that they are not left. If they must be left alone, put the patient into the recovery position, and this will help with lessening the chance of choking on any vomit. So this recovery position is rolling them onto one side with the top leg and arm crossed over the body, and that top knee is slightly bent, which makes it difficult for them to roll over onto their stomach. And so really, continuing any rescue breathing, as well as administering any naloxone, assessing response, checking for any breathing, slowed breathing, if they're still unresponsive. If they do wake up and start to breathe, stay with them. Again, naloxone has a duration of action anywhere from 30 to 90 minutes, and it can be very variable, especially with whatever the patient has ingested or injected. And so it's recommended to stay with them at least for 3 hours or until help arrives. One of the last things I wanted to provide you with were several ways on how to counsel your patients to avoid accidental overdose situations from occurring. First and foremost, take the medication only if it has been prescribed for you. As I had mentioned in the Attorney General's 2017 drug death statistics that was released in February of this year, most of the opioid or prescription drug deaths, they were not prescribed to that patient. So some ways that you can help this from occurring would be storing your medication in a safe place away from children and disposing of the unused medication properly, whether it's at a drug take-back day or in the trash. Learn how to do that correctly. Don't mix your opioids with alcohol, benzodiazepines, or other sedating medications. Remember how I mentioned that most drug deaths were caused by 2 or more drugs, with the average being 3, that involved 3 medications. Be extra careful if you miss or change doses, if you feel ill or starting new medications. One big counseling point, if any long-acting formulations are prescribed and it's a new patient, make sure to counsel them on not crushing, splitting, or chewing that, because that can accelerate or increase the risk of an overdose from occurring. And lastly, learn and be able to teach your family and friends how to respond to and learn the signs and symptoms of an overdose so that they can respond promptly and correctly. When approaching this topic of opioid safety, the term overdose has negative connotations associated with it and a negative social stigma. So when approaching the subject with patients, it can be a situation where you need to tread lightly and choose your words very carefully. In a study done by the San Francisco Public Health in 2013 and 2014, they reported that patients who were prescribed opioids, including those who are at high risk with a history of an overdose, they rated their overdose risk as a 2 out of 10. So this term overdose, patients may not even identify with. So consider using other terminology, such as if an accidental overdose were to occur, or if you had a bad reaction to your opioid, or just opioid safety as a whole. You can use phrases such as opioids can slow or stop your breathing. Naloxone is the antidote to opioids. It's either sprayed or injected if there's a bad reaction where you can't be woken up. And lastly, I like this analogy, naloxone is for opioids as an EpiPen is for someone with allergies. So just consider this when you're approaching your patients, having this opioid safety language. When an overdose occurs, it can likely be a very traumatic and life-changing event, and in most cases, it is unintentional. And the survivors of the overdose will likely need to cope with any emotional consequences such as guilt, embarrassment, or shame. Even loved ones may need to deal with feelings of guilt and being judged by others. And so most survivors, including their families, will actually need just some overall support, and family and friends can easily provide this, but others include recovery groups like Narcotics Anonymous. On a national level, you have the National Treatment Referral Helpline with the phone number listed there. Two locators include the National Substance Abuse Treatment Facility and Buprenorphine Treatment Physician and Treatment Program. Other groups include those affiliated with educational institutions, community support groups, and faith-based organizations. The last thing I wanted to provide you with were several resource websites that I found to be extremely helpful in the development of this presentation for both you as the clinician as well as the patient. The first thing being Pharmacist Letter's article on naloxone therapy. It is very thorough and also provides several quick reference documents, such as a specific talking point document that has tips for how to offer patients naloxone therapy and incorporating that into your workflow. The remaining are websites that I found to have very good material and brochures or pamphlets that are helpful for not only you as a provider but also the patient. You could easily print these off to have handy to distribute to patients that are free for the taking or while you are counseling them. In conclusion, naloxone is an opioid antagonist that will only work if opioids are present in the patient's system. It is not effective in reversing an overdose caused by benzodiazepines, barbiturates, cocaine, amphetamines, or other stimulants. It also does not possess any harm to patients if it is administered if there are no opioids in their system. Common signs of an overdose are respiratory depression, blue-gray lips and fingernails, as well as pinpoint pupils. Currently, there are 4 different formulations of naloxone that will be able to be dispensed to the public, but only 2 routes of administration, either intramuscular or intranasal. Each of the 4 different formulations have different administration techniques, so it's very important to properly counsel your patients depending on which formulation is dispensed to them. Most overdoses happen in private homes and or are witnessed by someone, whether that is a family member, a close friend, or another person. Increasing access to naloxone could significantly reduce the high number of opioid overdose deaths. When administered promptly, naloxone can save lives, even when given by a bystander. Lastly, and most importantly, naloxone is not a substitute for emergency medical care. 911 should still be called after administering that dose of naloxone. Now that we've concluded the lecture portion of this presentation, we'll now go into the assessment questions. The first assessment question is which of the following patients would not be considered at high risk of an opioid overdose? A 28-year-old male who was recently in the emergency room for an overdose. B, an 84-year-old male who has COPD emphysema, diagnosed with lung cancer 1 year ago, and has been using benzodiazepines for sleep and high-dose opioids to control his pain that are equivalent to over 100 morphine milliequivalents. C, a 76-year-old frail female who lives in Allagash, Maine, and has been using fentanyl patches for her chronic lower back pain, but the nearest hospital is 1 hour away. Or D, a 45-year-old male who uses OxyContin 40 milligrams daily and hydrocodone with acetaminophen 5-325 3 times a day as needed for breakthrough pain, with morphine milliequivalents equivalent to 75. The answer to the first assessment question is D, the 45-year-old male who uses OxyContin and hydrocodone with Tylenol, equivalent to 75 MMEs. The reason the 28-year-old male is considered to be at high risk is because of that number one risk factor being a prior history of overdose. The 84-year-old male is considered to be at high risk for two reasons. The first, he has concomitant respiratory disease with the COPD and lung cancer diagnosis. Secondly, he concomitantly uses benzodiazepines and high-dose opioids. The 76-year-old frail female, although she has been using fentanyl patches to treat her chronic lower back pain for years, the nearest hospital is an hour away, and she is far from emergency medical services, making her also high risk. This leaves the 45-year-old male, although he would be at risk for an opioid overdose, having any opioids on board causes one to be at risk, but this is not considered to be at high risk because he's at 75 morphine milliequivalents. The second assessment question is, as a Maine pharmacist under the Naloxone protocol, which of the following patients are you allowed to dispense to? A 35-year-old female who is picking up a prescription for oxycodone, who is also taking sertraline, lorazepam, and as-needed zolpidem. The mother of a 20-year-old male who is concerned that her child may be taking prescription drugs. C, a 17-year-old female who requests it. Or D, all of the above patients you are allowed to dispense to. The answer to the second assessment question is D. You are allowed to dispense to all of the above patients. The 35-year-old female is concomitantly taking an opioid in combination with an antidepressant, a benzodiazepine, and another sedative medication. The mother of the 20-year-old male can be dispensed to because she is in the position, she is a member of the patient at risk's immediate family, and she can assist the person if they are experiencing an opioid-related drug overdose. Lastly, the 17-year-old female who requests it can be dispensed to because she simply requests it. You are allowed to dispense naloxone to any person of any age if they request it. Assessment question number 3. Which of the following is not the correct drug and corresponding administration technique? A, FZO, remove the red guard, place the black end against the thigh muscle, press firmly, and hold for 5 seconds. B, the generic naloxone nasal syringe, placing the nasal atomizer into one nostril, giving a short, strong push and administering the full dose. C, Narcan nasal spray, placing the nozzle into one nostril and administering the full dose. And D, the generic naloxone injection, drawing up 1 ml into the syringe and injecting into the deltoid or thigh muscle. The answer to the third assessment question is B, the generic naloxone nasal syringe. It is right that you do place the nasal atomizer into one nostril and give a short, strong push. However, you do not administer the full dose because it is such a large volume of liquid. You need to space it out into both nostrils. So, you administer approximately half the dose into one nostril, remove the nasal atomizer and place it into the second nostril, and administer the remaining dose. With the FZO, it is voice prompted. However, you want to remove the emergency red guard, place the black end against the thigh. This is where the needle is going to come out. Press firmly and hold for 5 seconds. With the Narcan nasal spray, you do place the nozzle into one nostril, and because this is such a small quantity, you can't administer the full dose into one nostril. For the generic naloxone injection, you do drop 1 ml, whether that's from a single dose or a multi-dose vial, and then inject it into either the deltoid or the thigh muscle. Remember to counsel your patients on how to properly dispose of the syringes and needles with this generic naloxone injection. Which of the following is not a sign or a symptom of an opioid overdose? A, respiratory depression, B, large pupils, C, unable to be awakened, or D, all of the above. And the answer is B. Large pupils are not a sign of an opioid overdose. Difficulty and slowing of breathing is characteristic of an opioid overdose, which leads to respiratory depression. 2 other characteristic signs of an opioid overdose are pinpoint pupils rather than large pupils, and the patient is unable to be awakened. The last assessment question is which of the following is or are common side effects of both intranasal and intramuscular naloxone administration? A. Increased blood pressure, B. Bradycardia, C. Agitation or irritability, or D. Both A and C. The answer to the question is both A and C. Both the intranasal and intramuscular naloxone formulations are associated with increased blood pressure and heart rate, rather than decreased blood pressure and heart rate, which is the bradycardia. Naloxone is also associated with agitation and irritability, which is through the induction of the opioid withdrawal. Other symptoms of an acute withdrawal include body aches, abdominal cramps, as well as nausea, vomiting, and diarrhea. Again, an important thing to remember is that these symptoms are generally not life-threatening. They are just very unpleasant and will disappear once the naloxone wears off in the system. For specific intranasal formulation side effects, these are primarily local, causing nasal congestion and edema, as well as headache. For the intramuscular formulations, they are, for the most part, associated with injection site reactions. Thank you very much for taking the time to listen to my presentation. Those YouTube videos on administration techniques for each of the formulations were very helpful to better wrap my mind around it and in turn be able to teach patients the proper technique. I highly recommend watching those videos. Also, here is the link to the assessment questions and evaluation survey. Please complete this for my purposes as well as yours so that you can get the credit for these 2 CE hours. It should take approximately 10 minutes to complete that. Lastly, do not hesitate to contact me with any questions that you may have at the email address listed here. Again, thank you very much for taking the time to listen, and good luck.